65-year female, normotensive, non-diabetic, sudden digital ganglion involving all the folds, along with an abdominal pain. This was her clinical picture, and she was hemodynamically stable, unlike other cases, but having acute shortness of breath, and this was her radiology, shadow involving both the lower and mid on both the sides. And her lupus anticoagulant and antiphospholipid antibody was very high positive. She had evidence of respiratory failure. She could document the evidence of active urine sediment in addition to respiratory failure. So this was a case of catastrophic antiphospholipid antibody syndrome, presenting with acute arterial thrombosis, respiratory distress syndrome, along with acute glomerulonephritis. So the patients presented in any patients of inflammatory polyarthritis with all sorts of rheumatological problems can present with CNS manifestation, with acute psychosis, or generalized tonic-clonic convulsion, or even with mononeuritis multiplex, like sudden wrist drop, sudden foot drop like that, or even myelopathy in the form of acute paraplegia, or even AID. So this is one of the very important neurologic manifestations. One can present with acute chest pain due to coronary syndrome, even in the age of 25-30 years, can present with shortness of breath due to heart failure, or even due to pulmonary manifestation. Could be due to ARDS, could be due to lupus pneumonitis, or could be due to infection. Very often, the most challenging task of the training physician is to identify in a patient of systemic lupus with high fever and cough with pneumonia, whether it's due to infection where one should institute antibiotic aggressively, or is due to activity of the lupus where one would require intervention with corticosteroids. So that's the most important task one has to identify. And third part is acute abdomen. Fourth part is acute renal catastrophe. Acute renal failure in the form of glomerular injury, renal failure in the form of interstitial injury, or even vascular injury. But the last and most important part is drug-induced acute emergencies. A patient who is on immunosuppression, presenting suddenly with cytopenia and infection. So that's a very important emergency. Or drug-induced GID, NSAID, corticosteroid-induced GID. So iatrogenic emergencies in the rheumatology practice also very important, and we should not forget. I think these are the things which I try to share with you, and this is the important list, like necrotizing vasculitis, catastrophic antiphospholipid, hypertensive crisis in reference to SLE program or renal crisis, and yes, I forget to mention the septic arthritis and emergencies in reference to joint. Patient can have a ruptured Baker's cyst in a given patient of osteoarthritis, suddenly presenting with acute pain and swelling left out, mimicking deep venous thrombosis. And if we cannot identify or differentiate DVT from Baker's cyst rupture, it's very difficult to plan for the therapy. So that's important. In a given patient of deformed rheumatoid, one can present with an atlantoaxial dislocation with quadriplegia. This is another very important arthritic emergency. For neurology, we have discussed this part, and you can give a cardiac emergency. These are the very important respiratory failure. And the next, renal, and another very important emergency is ocular. Patient can have an acute blindness that could be either painful or painless, and can have this anatomical compartmental involvement. Patient can have bilateral red eye, acutely developing, or can have an iritis, or can have an scleromenasia pulsar. So these are the optic emergencies in rheumatology practice is also equally important. I think these are the patient can present with an acute onset painful eye or painless visual loss in the form of ischemic optic neuropathy in Takayasu arthritis or hypertensive crisis or stroke-like situation. So I can stop here. These are the spectrum of emergencies one can come across. I mean, another part is just skin rashes. Stevens-Johnson syndrome, one should not forget, in reference to either lefuramide or in reference to other immunosuppressives like that. Thank you very much for your patience.
Thank you, Professor Bose, for your beautiful this presentation. I hope definitely this different enlightening to our audience to look seriously into those problems, taking into the line of in the line of the topic. So thank you, sir. Thank you very much for your elaborate presentation, sir.